reversal. Following his training with Professor Dale Bredesen, his new specialized mission is to dramatically improve the screening, prevention and treatment for all people with cognitive decline in Australasia, and is planning to collaborate with Australian scientists in a multisite trial of the Bredesen Protocol. So he's going to tell us about that. Thank you very much, Dale.
Thank you, Tim, and kia ora to fellow colleagues from New Zealand. I understand there's about 35 ways to say good morning in Aboriginal language, so I won't attempt. But thank you, Bram, for the invitation to speak, and especially in this wonderful city full of artful, sophisticated hippies. And the timing for me was great, because on Friday I had the choice between a Van Gogh exhibition or the International Beer Festival. And unfortunately, I chose Van Gogh for my brain. But I'm going to give you a sort of a practitioner's application of the wonderful academic work that's being done by our colleagues here. And let's hope we have no technical problems. Which button do I press? The green one? Top green one. Yay! Okay, so look, in 2014, while being very passionate about functional medicine, both my parents were diagnosed with Alzheimer's. One, my mother with traditional Alzheimer's, my father with vascular dementia. And I went looking for a functional medicine approach, so at least I thought maybe I could slow this down and make the quality of life, and found Dale's work. Now, this is his first paper. There's another one in 2016, which I suggest you read both. But the 16 one outlines some more hard data about the cognitive reversal. I was absolutely excited about this because, as you know, well, to my knowledge, there's no one actually been officially diagnosed with Alzheimer's that has been undiagnosed at a later time. And that's what we're at least experiencing on an anecdotal case basis. So I directly emailed Dale, and he jokes with me now and apologised for taking 1 year to get back to me, but he does respond better now. But it's quite extraordinary work, and Dale's someone who's been studying why brain cells die for over 25 years, and so this is a very established neuroscientist. So that got me pretty excited, and I've been over there 2 times now to train with Dale. So what's that all about? Well, he describes initially 36 holes in the roof. He thinks there's going to be about 80, and we've heard a lot of them from Ralph and Ross about these perturbations, what he calls them, holes in the roof, and why 244 drug trials in the last 10 years have completely failed is because the only chances they have would be to plug 1, possibly 2 of the biological pathways that lead to the pathogenesis of Alzheimer's. And as discussed, I'm kind of fascinated by this, and even so any theoretical model of the causation of Alzheimer's that we could lead to a therapeutic protocol must have somehow explained why all these risk factors, how they all come together to create the plaques and the tau. And even as fascinating to me was that air pollution is the latest kind of thing, and they're finding micro pollutants in the brains of mice, and there's certainly some association the closer you are to a main highway. There seems to be some increased Alzheimer's. So you know all these. I want to move quickly on to what Dale and what others are thinking might explain how this works. And we've discussed this is the amyloid pre-protein sitting on the cell membrane of a neuron, and it has a couple of options. It's like a switch. It can go left and divide into 2 peptides, and that seems to create synoblasty. So the model seems to be similar to osteoporosis. So it can bring synapses together. Whereas if under duress and metabolic perturbations, it can go to the right, and it can split into 4 peptides, one of which, of course, is the amyloid beta. Now, it appears that that is a signaling molecule that can then also create inflammation, mitochondrial dysfunction, and synoclasty, literally, certainly in the mice models, pulling the synapses apart and neurons dying, and hence hippocampal shrinkage. And what another piece of Dale's work, which I am finding as a practitioner, I am finding similar things, but not always exactly. Large data sets will enable us to subtype the type of dementia or Alzheimer's and therefore customise a personalised approach. And I think Marley will talk a bit more about this in the next talk. But certainly I'm finding in my patients that they can fit in there. The issue of the mix of vascular becomes a real issue, and you kind of, and I joke with Ralph that we're just basically loading a shotgun and firing at the tiger that's running at us. We're not quite sure at which point it's working, but it does seem to be working for some people, so we'll talk about that. Here's a case of Dale's. This is actually a doctor, a genius, who went to Berkeley at 16. You'll see he's 4'3" there, and he's the metabolic perturbations that we've all talked about, very high fasting insulin. Hopefully most of you are less than 7, even less than 5, and you don't have any insulin resistance. But he's inflamed, he's high homocysteine, he's low D3, he's really struggling. And what was very, very significant about this case was that only after 10 months on these protocols, all of these parameters fixed, and his hippocampal volume had increased from the 17th percentile to the 75th. Now, we've never heard of this happening. We know that exercise can boost it a little bit, but the radiologist rang Dale and said, I don't believe it, I've done 75,000 scans in this lab and we've never seen it, I'd like to put 35th percentile. And Dale said, well, no, send that off to an independent lab who confirmed, in fact, it was the 76th percentile. So something clearly is going on with these protocols that is highly therapeutic. Now I want to talk about one of my patients and one of my cases. You'll meet him soon in a video clip, but this is Roy, and again, a typical sort of a picture, ApoE4, a long history of memory loss. He was diagnosed with Alzheimer's by a specialist in 2014. Interestingly, he had vasculitis in 2014. I do all the intestinal permeability tests initially on anyone with autoimmune disease, but now I'm doing it on everyone because I find I haven't had a negative test yet. So he's also got some vascular issues, aortic regurgitation, pacemaker, a low blood pressure. There's some evidence I read the other day that actually if you've got moderate Alzheimer's, minor Alzheimer's, don't drop the blood pressure too low because you're going to keep pushing that blood and oxygen through. But yeah, so he's also interestingly had a bipolar disorder, sleep apnea, and the issue of sinusitis is interesting, but I won't get into it. So if we look at his metabolic parameters that we checked, again we see these disturbances. The copper-zinc ratio is high, the D, and the low sex hormones. And he's mildly anemic, and I think when the mild anemia with, or borderline anemia with this low blood pressure, you wonder how oxygenated his neurons are. So this is Roy. We put him on the protocol, and this is...
Roy was diagnosed with Alzheimer's in 2015. So we had always started using the coconut oil and what we could of the Bredesen program, which we had seen on the computer. So since he started the program properly in October, there have been huge improvements. So much so, in fact, that I treat him like an ordinary person now, and not like somebody who's ill at all. He got quite depressed at one stage and angry with what was happening to him, but now I see my lovely husband once again. So it's just wonderful, and thank you to Dave for bringing this program to New Zealand.
Thank you. Morning. I'm Roy, subject of this program, and I find it very hard to believe how much improvement I've made since being on this program. I feel great, I feel optimistic, and looking forward to the future. These things were not possible a year ago. I just wanted to fade away and not think about anything. And now I'm looking forward to things, and thank you very much, Dave, for having us on this program.
Hi, I'm Maria. I'm a community advisor for Alzheimer's Northland. I have the great privilege to have Roy as one of my clients, and I've seen the change since he's been on the program, and it's been phenomenal for me. I've never ever seen anyone with dementia ever get better. So great belief in what you do.
Apologies for the photographic madness there. I'm not the world's best videographer. But let's look about what this program is all about. And it seems to me there's you probably agree, there's quite a lot of madness, I would describe, in medicine. And one of the madnesses is this idea that mathematical bell curves and normal valuations are the way to move forward. And clearly, and certainly if you've got cognitive decline, it's not what we want to do. So we want trying to optimize all these metabolic perturbations. So a B12 of 300 might be okay if you're a fit 30-year-old, but it's not okay if you've got cognitive decline. So we get it to at least 500, hopefully up to around 600 level. So that's an example. We're looking to optimize all of these things, looking to turn that switch towards the two peptides and the cyanoblasting. So it seems that for some people, and I really don't tell any of my patients this, I tell them I have to do all of it, but certainly Dale's documented cases where people have got better without fixing all their perturbations. They sort of, and certainly what I'm finding quite consistently is people start to get more energy. You know, they stop needing the nap in the afternoon, and then the cognition kicks in later. So the brain optimizing diet, it's kind of the Mediterranean diet on steroids. We include the things like the pomegranates and the blueberries, and we look at cacao and the high flavonoids, which are looking very interesting in the research. I didn't know that you called it autophagy or autophagy, I'm not quite sure, but I think the idea of actual extended fasts is looking quite attractive too, but certainly a 12 to 16 hour, or eating in an 8-hour window with perhaps once a week, pushing it out to a 24-hour fast. Looking to create that autophagy. Exercise, sleep, stress management, and meditation. And this is a tough one for elderly people. And some of you look up Rudolf Tanzi, Professor of Neurology at Harvard, just published a paper about how meditation can upregulate good genes and downregulate inflammatory genes. And so this is the kind of hard data that I seem to, the spouses usually of my clients say, it's not a religious experience, it's a medical experience, and you need to do it. Neuromodulation, we're getting quite excited about using, brain training obviously as a brain HQ. Look at brain HQ compared for your clients, patients more than anything else. Look at the science behind that, but also I'm looking at the use of photons and lasers through the nose into the hippocampus, through the skull. There's early work. Professor Hamlin at Harvard is looking like this may have a role to play. Supplements, obviously, this is a big issue. We customise depending on metabolic perturbation, but we do use a lot of supplements. We do use the Bs. We are using nicotinamide riboside, and we are using glutathione and ginkgo, and so it is a shotgun approach with some customization. And I try and get people off some of the things if they start to get better, if that's a possibility. And what's really critical here is a specialised type of coaching. This is kind of a complex, and it's difficult for most people to apply in their daily life. And there's a lot of behaviour change strategies and techniques you need to know and be good at to successfully get this kind of change. And that's definitely one of the challenges moving forward. The challenges that I think we're going to face with certainly with my vision, this kind of silver bullet research mindset that we have. And Dale tried to get a trial going in Australia 4 years ago. He was told, this is a guy who's published a couple of hundred papers. You don't understand trials. And he said, well, you don't understand Alzheimer's. And interestingly enough, the ethical committees that said no way, some of them called him later and said, look, by the way, my mother's got Alzheimer's. I'm like, can you tell me what you're doing? And this is actually, I was there 10 days ago, and these stories continue, because the control trial that we're wanting to set up in England was facing a similar mindset from the NHS, and their madness is that if this was proven to be effective, we couldn't apply it within our NHS guidelines. So complete madness and lack of innovation in a field where we really desperately need innovative approaches. And it was, I think, Ralph that suggested we do need to look at Dale's cases and have an independent review of them and look at the data. But I've certainly met some of his cases and clients, and they're certainly a lot better, and some of my patients, it's early days, are certainly starting to get better. Look, the investigations can be expensive. John just told me the Nutripath kind of bulk investigations of $5,000 to get everything done to check all these perturbations. But if you're got this disease, then you are really often willing to pay that. It can take a lot of time, and we're working on a software, or Dale has a software coming out, and we're certainly working on coaching systems and systems to dramatically reduce the time that you need to spend with clients. But that 100 hours is just a rough guess between coaches, nutritionists, myself, GPs. And it's too expensive right now. But when you look at the economic impact of Alzheimer's, it's somewhere between $500,000 to $750,000 from diagnosis to grave. So I'm estimating this program, well done with the support of government for testing, would be coming somewhere around the $30,000 mark. So I think if there's any way of getting these protocols implemented at scale, it's going to be the economic argument that wins the day. So the current stats from Dale is, and I was just getting these very recently, 239 clients, SCI, MCI and early Alzheimer's, but there are some moderate Alzheimer's that are responding as well. This is quite a dramatic cognitive improvement consistent with this first series of cases, and I like this third one that 3/4 of people that had to leave work were able to go back to work. And Dale's asked me to, with a number of other practitioners, to put together our cases in a separate paper to his. There is a multi-site controlled trial that hopefully will begin this year. Dale's lab, Cleveland Clinic, and that's actually Lancaster University. And we would like to be involved in Australia if possible. The Californian government is talking about a 1,000-person trial because their costs, their estimate for managing Alzheimer's, will triple in the next 3 years. So these trials are going to occur if we can get over the ethical mindset and get them to approve a kind of a multivariate analysis approach with a controlled cohort to look at the statistical difference between the current therapeutic program, which is, let's agree, it's nothing. I'm always saddened by 4 pages of geriatrician's report on the patient, and then there's one line that says, I have encouraged them to have a healthy diet, do some exercise, and maintain their social contacts. And I sort of think I'd like to see 4 pages on how you advise your patients to do that, and 1 line on their cognition. That would be better. So look, I'm a kind of take on big mission kind of guy. I swear to myself this is my last time I'm going to do it. But you have to be careful. But the future vision is that the trials, there are some new drugs. We hope for drugs. We hope that they really will contribute, but it's unlikely they're going to do the whole job. There's some extraordinary supplements. There's a Dale's trialing. There's actually from the coffee pulp, not the bean, that increased brain-derived neurotrophic factor 10 times more than exercise. We don't know its safety range right now, but it's certainly looking optimistic, and there are some other supplements being trialled right now. The neuromodulation tools that I've discussed. We've got a massive job, assuming these trials show some statistical difference and improvement, a massive job, and certainly be looking to ACNEM to lead the way, assuming we have the evidence to support that. And it's a team approach. We need coaches, and nutritionists and coaches are critical to this. The diet is probably somewhere around 50% or more of the therapeutic response, especially if we can customize it as well. And there's I think the critical thing here, and certainly when we lobby our political friends, we need to have a colonoscopy at 55, not just a colonoscopy, and hopefully it's either an amyloid scan in the retina, but there's some very exciting work coming out from a lab in America, which neuronal exosomes, which are fragments of brain cells, they find themselves in the blood, and we can find out the amyloid load from that, and we can find out how insulin resistant it is. So there's a future for early diagnosis and cognostic. That's where the real use of these protocols are going to be very powerful, I think. And of course, the question, I'm trying to act ethically is, should I be even doing this? And I had a letter from a geriatrician to the patient suggesting that this was nothing but a scan. And I think we have to keep that in mind. But as Felice said, this seems to make sense. We know neuroplasticity is huge, so take away the things that are damaging it, increase the things that encourage neuroplasticity, and it does appear we can get true reversals. They're not cures. People come off these protocols, they get it back.
but it does appear that we have, at least Dale has, and others are starting to crack the code on some effective therapeutic program. Thank you.